Welcome back to Open School. Today I'll be discussing a few MCQs on hepatic encephalopathy. Last time we have discussed about the clinical manifestations of hepatic encephalopathy and the investigations. So this is a history of a 60-year-old woman with cirrhosis due to non-alcoholic fatty liver disease or the metabolic associated liver disease. She is acting strangely, reported as awake at night and drowsy by day. For the last 1 week, is forgetful, irritable, and she got lost while returning from bathroom. On examination, she is awake, but slow answer to questions, disoriented to time, and has got flapping tremor. The lab results are given. She is jaundice with bilirubin of 4.5, hypoalbuminemia of 2.6, sodium 128, potassium 3.2, and the serum ammonia is mildly elevated. So this is a classic case of hepatic encephalopathy. So question is, what is the most likely grade of hepatic encephalopathy? Any patient with hepatic encephalopathy, you have to grade the hepatic encephalopathy. Traditionally divided into 4 stages. So this patient has got overt hepatic encephalopathy because of the clinical findings which I have already mentioned. Asterisk indicates hepatic encephalopathy grade 2. So this is the take home message. Asterisk indicates either 2 or 3. So here the patient is having lethargy, moderate confusion, disorientation, and hysteresis. This is grade 2 hepatic encephalopathy. So grade 4 is common. Grade 3 will be more confusion. Patient will be stuporous and flapping tremor can be present. Now we go to the next question. Which early symptom supports hepatic encephalopathy? Most important point, remember, early changes in the sleep pattern, reversal of the sleep rhythm or inversion of sleep rhythm is the classical early finding of hepatic encephalopathy. So as per up to date, disturbance in diurnal sleep pattern are common initial manifestations of hepatic encephalopathy. Insomnia and hypersomnia are often the first sign. Again, this is a point to be kept in mind. Now we go to assertion reason type of question. Assertion: patients with minimal hepatic encephalopathy may appear asymptomatic on routine examination. Reason: subtle cognitive deficits require psychometric or other tests for detection. Both A and B are correct. So minimal hepatic encephalopathy may be detected using specialized tests only, as per Davidson's principles of and practice of medicine. So early hepatic encephalopathy patient may go unnoticed. Next we go to which lab abnormalities or abnormality supports precipitant hepatic encephalopathy in this patient. Our patient had hyponatremia and hypokalemia. So these are precipitating factors in this patient. Electrolyte imbalance such as hyponatremia and hypokalemia are important precipitating factors. So look for hyponatremia and hypokalemia whenever patient has got alteration in the mental changes in a cirrhotic patient. One more assertion reason question. Venous ammonia levels are definitive for diagnosing overt hepatic encephalopathy. Reason: high ammonia levels are always correlated with the severity of metastatic changes. Remember, venous ammonia levels are not definitive. High ammonia levels are always correlated with severity. That is to assertion and reason both are incorrect. So remember this point. Even though ammonia is a important supportive evidence, ammonia levels may be normal in patients with hepatic encephalopathy. They do not correlate well with clinical severity. Even though there is a positive correlation, it may not be true always. So, correct answer we have mentioned. Which bedside test is most specific for overt hepatic encephalopathy? We have already mentioned the flapping tremor is the most important early bedside test. Now we do, which is true about psychometric tests? We have mentioned that in patients with mild hepatic encephalopathy can be missed. They are quick and easy. They can detect overt hepatic encephalopathy reliably. They are used routinely. They replace the need for history and examination. So, which is true? They can detect not overt but covert hepatic encephalopathy. So last time I mentioned about the hepatic encephalopathy divided into overt and covert. So mild and covert hepatic encephalopathy is detected by psychometric tests. They are not easy. They can detect covert. They are not routinely used. They don't replace the need of clinical examination. So subtle changes like behavioral changes, inversion of sleep rhythm are more useful. Assertion reason. The animal naming test can help to detect covert hepatic encephalopathy. Reason: it tests attention and semantic memory by counting unique animals named in 1 minute. You ask the patient to count the number of animals they are able to count within 1 minute. The assertion is correct. Reason is also correct. Which of the following investigation is not routinely helpful in suspected hepatic encephalopathy? A blood glucose has to be done. Serial electrolytes must be done. Routine MRI for the patients are not done. Whenever there is a trauma or focal deficit, you go for imaging. CT brain is reserved for trauma, focal signs, sudden deterioration. Routine MRI is not indicated. Again, keep this point. One of the indications for imaging: patient is not responding to treatment, or the patient has got evidence of focal signs, history of trauma, or whenever the patient suddenly deteriorates, which you cannot explain, go for imaging. So in this session, the take-home messages are the sleep wakes reversal, mood changes and confusion. This is the very important. Ammonia is always not diagnostic. Always look for bleed, infection, electrolytes, and of course blood sugar. Psychometric tests are useful for covert hepatic encephalopathy. Bedside examination is always vital. There is no substitute for careful clinical examination. The next session will continue with the further questions.